paint this picture in your mind. You're looking at a 71-year-old man.
Okay.
He is retired, he's sharp as a tack, and he is out there pushing the mower across his own lawn every single Saturday morning.
Sounds like a great setup.
Right. He's driving himself to a regular Tuesday night poker game. He has his routine, his independence. His whole life is just perfectly dialed in.
He is, by every practical, biological, and social measure, just completely thriving.
Exactly. He is absolutely winning at aging. But his wife, out of a place of deep love, drags him in for a routine physical that he's been putting off for, a couple of years.
Which happens all the time.
Yeah, all the time. So he sits on that crinkly paper on the exam table. The doctor listens to his heart, taps his knees to check his reflexes, and says everything seems completely fine.
That's the best news you can get.
It is. But then the doctor adds those 6 specific words that completely, entirely alter the trajectory of this man's life. He says, let's just run a few tests.
Which, if we are being honest, sounds incredibly responsible. I mean, it sounds like exactly what you want a doctor to say.
Right. It feels like the actual definition of good medicine, just checking under the hood. But fast forward exactly 3 months.
Okay.
That same 71-year-old man is not mowing his lawn. He is recovering from a major medical procedure that he absolutely never needed for a biological quirk that would never have actually touched him.
It's just devastating.
It really is. He is dealing with severe surgical complications that have literally nothing to do with why he originally walked into that clinic. And the version of his life that he had before that appointment, the lawn, the poker games, that beautiful, hard-earned independence, that version is entirely gone.
And, the most chilling part of the clinical data we are looking at today is that this story is not an anomaly. It's really not.
Wait, really? It feels like a freak accident.
No, it is not a rare surgical mistake. It isn't a freak accident at all. This precise sequence of events has a formal name in medical literature. It has a highly predictable, almost inevitable mechanism once it gets started. And it is happening in clinics and hospitals every single day.
Today's deep dive is entirely focused on unpacking this shocking phenomenon. We are looking at decades of clinical data, looking specifically at the lived experiences of veteran geriatricians and cardiovascular specialists who have seen the inside of this machine.
Yeah, these are people who've spent 30, 40 years in the system.
Exactly. And the overarching conclusion points to a staggering reality. Listen to this. Between 15 and 25% of all medical procedures performed in the United States every single year are completely mathematically unnecessary.
It is a staggering volume of overtreatment.
Yeah.
But what we really need to focus on is why the fundamental logic of preventive medical screening, the math we all rely on, flips completely upside down after you reach the age of 65 or 70. We're going to look at the exact cellular and physiological mechanisms of bodily stress caused by overdiagnosis. We have to explore how a perfectly healthy organism can be actively, irreparably damaged by the very medical system designed to protect it.
Okay, let's unpack this, because everything we are about to discuss feels completely counterintuitive. I mean, it violates everything we've been taught, right?
Oh, absolutely. It's a complete paradigm shift.
We have been conditioned our entire lives to believe that early detection is the holy grail. Catch it early, fix it, live longer. It's practically a religion at this point.
It is the bedrock of modern public health messaging.
Yeah. But to understand why these veteran doctors are raising this massive red flag, we first have to completely rewire how we think about aging and medicine. We have to look through a concept known as the longevity lens.
If we connect this to the bigger picture, the longevity lens is really about respecting how biological math changes over time.
Okay, how so?
Well, when you are 50 years old, the screening math is incredibly clean and straightforward. You do a routine test, you find a microscopic problem early, you treat it aggressively, and by doing so, you potentially buy yourself 30 or 40 good, healthy years.
Right, because you have all that time left on the clock.
Exactly. It is an excellent return on biological investment. The risk of the treatment, say a surgery or a course of harsh medication, is easily outweighed by the decades of life you gain.
But the data shows that after age 65 or 70, that math just fundamentally shatters. And there are 3 distinct biological reasons why.
Right.
The first is something called indolent abnormalities. And this, honestly, this blew my mind. Tell me if I have this right. As we age, our bodies develop quirks, little growths, narrowings in our vessels, calcifications.
Yes, exactly.
But many of these things are indolent, meaning they grow so incredibly slowly that they will never actually cause a symptom in your remaining natural lifespan.
You have it exactly right. Indolent literally means lazy or sluggish.
Lazy cells.
Yeah, lazy cells. At a cellular level, these abnormalities are barely replicating. In the context of an older adult, you're going to die with these quirks, not from them.
Wow.
Finding them doesn't give you a head start on saving your life. It just gives you a terrifying label for a biological artifact that was perfectly content to leave you alone.
Which fundamentally changes the definition of what a quote-unquote disease is in an older body. And that brings up the second factor, which is decreased tolerance.
Yes, biological resilience. An organism at 50 has a vastly different resilience profile than an organism at 75.
Because things just don't bounce back the same way.
Exactly. Think about cellular regeneration, inflammation management, or cardiovascular elasticity. A surgery that a 50-year-old bounces back from in 2 or 3 weeks can easily plunge a 75-year-old into months of grueling recovery.
That makes total sense.
And in many cases, that severe systemic shock forces them across a threshold into permanent fragility. They lose their baseline, and they simply never get it back.
I kept thinking of this like cars. It's like bringing a modern sports car to the mechanic versus bringing in a vintage classic car.
Oh, that's a great way to look at it.
Because with the modern sports car, you plug it into the diagnostic computer and you aggressively replace every single slightly worn part immediately to keep it at peak performance.
Right. The system can take the stress.
The car can handle being on the lift. But with a classic vintage car, pulling the entire engine block out just to fix a minor harmless rattle might actually warp the chassis. The intervention itself breaks the car.
That is a remarkably accurate analogy. The vintage chassis simply cannot tolerate the heavy machinery of the intervention.
Yeah.
And that leads directly to the third factor, which is the systemic flaw in modern healthcare itself.
The machine.
The machine, exactly. Our medical system is an absolute marvel of engineering, but it is built almost entirely around a highly calibrated, heavily funded treatment button.
Right. Find a problem, press the button.
Yes, but it severely lacks a leave-it-alone button. Once a result, literally any result, appears on a laboratory report, the machinery of medicine just does not know how to shrug.
Wait, but doctors are smart. I mean, they know the difference between a 50-year-old and a 75-year-old. Why can't they just look at the report, look at the patient, and say, let's leave this alone?
Because of the environment they're forced to operate in. What's fascinating here is the sheer systemic pressure of the modern 15-minute clinical appointment.
Oh, the time crunch.
It's massive. A doctor simply does not have the time to sit down and do this complex, highly nuanced risk-to-benefit math out loud with you.
Because it's not a simple conversation.
Exactly. Explaining the statistical difference between a slow-moving indolent anomaly and a critical fast-moving threat takes an hour of deep conversation.
And they have, what, 10 minutes?
If that. Under the immense pressure of time, and frankly the pressure of medical liability, they default to the standard protocol, which is test, find, treat.
Okay, so what actually happens when that treatment button gets pressed on a healthy, older adult? How do we get from a routine physical to the catastrophic loss of independence we talked about at the beginning?
Right.
This brings us to the actual architecture of the harm. The mechanism is called the cascade effect.
In the clinical literature, this is referred to as physiological iatrogenesis.
Okay, that's a heavy term. Break that down for me.
Iatrogenesis translates to harm caused by the healer or harm caused by the medical examination and treatment itself.
Wow. Harm caused by the healer.
Yeah. And the critical thing to understand is that it rarely happens all at once. It is not one giant surgical mistake. It happens as a cascade, a highly predictable step-by-step sequence of escalating interventions.
So it starts with that routine test on someone who feels perfectly fine. They're totally asymptomatic. The test finds a tiny abnormality. And because of legal and ethical protocols, that abnormality mandates a follow-up scan.
Precisely. And the follow-up scan is usually a higher resolution, which reveals something slightly ambiguous.
And ambiguity is bad.
Ambiguity in medicine mandates a biopsy to rule out the worst-case scenario.
Always hunting for the worst case.
Always. So the biopsy, which involves physically piercing tissue, leads to a surgical procedure to remove or fix whatever minor anomaly was found. And finally, the procedure itself causes a severe complication.
But here's what really stuck with me from the data. The damage isn't just that final surgical complication. The biological stress, the actual physiological harm, begins the second the cascade is initiated.
The biological toll is deeply cumulative. Think about the physiological response to this cascade through the lens of the HPA axis, the body's stress response system.
Okay.
The acute anxiety of simply waiting for scan results spikes cortisol and adrenaline.
Just the waiting alone.
Just the waiting. This elevates blood pressure and increases endothelial stress, meaning stress on the delicate lining of your blood vessels.
So you're taking physical damage just from the worry?
Yes. Then you have the physical trauma and infection risk of the biopsy needle. Then you introduce the heavy systemic burden of general anesthesia, which is incredibly toxic to an aging brain and cardiovascular system.
I didn't even think about the anesthesia part.
It's massive. This is an actively damaging sequence unleashed on a body that was completely at equilibrium before that first test. The cascade destroys the patient's quality of life before the quote-unquote disease ever even had a chance to.
I hear you, and, the biology makes sense, but I have to push back a little here.
Go ahead.
I just can't imagine a highly trained physician knowingly initiating this devastating sequence if the person sitting in front of them is perfectly fine. Why not just say no? Why not just stop the cascade?
It comes down to human psychology and the deeply defensive nature of modern medicine.
Defensive medicine.
Right. If a doctor sees a potential issue, decides to do nothing, and that issue later becomes a life-threatening problem, that doctor is legally liable and professionally devastated.
Because they missed it or ignored it.
Because they failed to act. However, if they treat it, and the treatment causes a massive complication, well, that is considered an acceptable, quote, known risk of the procedure.
Oh, wow. So the system covers you if you act, but destroys you if you wait.
Exactly. The system forgives action. It violently punishes inaction. Furthermore, we are culturally conditioned, both doctors and patients, by the way, to believe that action equals care and inaction equals negligence. Doing nothing feels wrong.
So we have this systemic trap where literally everyone means well, but the outcome is catastrophic.
That's exactly it.
And the data doesn't just talk about this cascade in abstract theory. It outlines 5 specific, incredibly common routine checkups that perfectly illustrate this trap.
Yes, 5 major ones.
Let's look at the first one, which targets the engine of the body itself. The cardiac cascade, specifically routine stress tests.
Okay, so we are talking about routine cardiac stress testing. This usually involves putting a patient on a treadmill, or if they have mobility issues, using a chemical injection to artificially simulate exercise by racing the heart. And we are talking about doing this on asymptomatic patients over 65. People who have absolutely no chest pain, no unexplained shortness of breath, and no exertion-triggered dizziness.
And again, to a layperson like me, that sounds so responsible. Hey, you're 68, let's just make sure the ticker is holding up under pressure.
It sounds totally logical.
But the statistical flaw buried in this routine test is just mind-blowing.
It borders on statistical absurdity, frankly. In certain populations of asymptomatic older adults, the false positive rate for these routine stress tests can reach up to 40%.
Wait, pause. 40%.
Yes.
Almost half the time, the test screams that there is a heart problem when the heart is completely fine.
Almost half the time.
How is that even mathematically permissible for a screening tool?
Because the test is looking for microvascular changes and reacting to the natural benign stiffening of the heart muscle that occurs with age.
So it's confusing age with disease.
Exactly. It flags these normal age-related changes as pathological blockages. But here is the trap. Medicine cannot ignore a blaring alarm, even if they know the alarm is faulty 40% of the time.
Right, because of the liability.
That false positive immediately forces the doctor's hand, plunging the patient into the next highly invasive phase of the cascade, which is a cardiac catheterization.
And a catheterization is not just taking a picture. You're not just sliding into an MRI tube and listening to some music.
Not at all. It is a highly invasive mechanical intervention. A cardiologist threads a thin tube, a catheter, through your blood vessels, usually entering to the femoral artery in your groin or the radial artery in your wrist.
Ouch.
And they push it all the way up directly into the chambers of your heart to inject contrast dye and look around.
So you're literally pushing a foreign object through the delicate plumbing of a 70-year-old's cardiovascular system. That has to introduce immediate risk.
Severe risk. You are introducing the risk of major arterial bleeding. You can cause permanent vessel damage. You can trigger new chaotic arrhythmias just by the physical irritation of the catheter touching the heart muscle.
Just by bumping into it.
Yes. And in rare but very real cases, the catheter itself can physically scrape against the wall of an artery, dislodge a piece of stable plaque, and trigger the exact heart attack or stroke you were doing the test to prevent.
That is just the ultimate tragic irony.
It really is.
But let's follow the cascade further. Let's say they get in there, they do the catheterization without causing a stroke, and they find a partial blockage. From what the clinical data suggests, finding a partial blockage in a 70-year-old is practically guaranteed, right?
Oh, absolutely.
It's like finding gray hair.
Precisely.
Yeah.
It's a normal artifact of human aging. But what is the treatment trap here? Finding a stable partial blockage almost inevitably leads to the placement of a stent.
Which is like a tiny metal cage.
A tiny metal mesh tube to physically prop the artery open. And once you have a stent, you are mandated to be on aggressive, heavy-duty blood thinners for years to prevent clots from forming on that foreign metal object.
But this is where the data completely drops the floor out from under this entire practice. Let's talk about the ischemia trial.
Ah, yes, the ischemia trial.
This was a massive landmark clinical study, and it looked specifically at this exact scenario. And what it found was that placing a stent in a patient with stable coronary artery disease does not reduce the risk of future heart attacks, and it does not extend life compared to simply taking standard medication and managing your lifestyle.
That is the absolute crux of the issue. The highly invasive surgical stent, carrying all of its immediate procedural risks and lifelong pharmaceutical burdens, statistically did not outperform a daily 30-minute walk and optimal basic management of blood pressure and cholesterol.
Think about that. Put yourself in that exam room, you walk in feeling totally fine.
Completely asymptomatic.
Right. You fail a statistically flawed treadmill test. You get your groin sliced open, a tube shoved into your heart, a metal cage permanently implanted in your artery, and you are put on lifelong blood thinners that make you bruise if you bump into a door.
It's a huge burden.
And after all that trauma, your actual life expectancy hasn't improved by a single day. You haven't bought any extra time. You have simply inherited procedural risk and massive daily inconvenience.
It is the perfect distillation of physiological iatrogenesis, intervention without biological benefit, carrying massive cascading risk.
So we've got this obsession with the body's plumbing. We think if we just find a clogged pipe and clear it, the house stands forever.
Right.
And that urge to clear the pipes doesn't stop at the heart. Let's move up to the neck. The second major trap is the vascular cascade, routine carotid artery ultrasounds.
Yes, this involves placing an ultrasound probe on the side of the neck to evaluate the carotid arteries, which are the massive highways carrying oxygenated blood straight up to the brain.
And again, the mechanical logic is incredibly seductive, right? Check the pipes, find a blockage before it causes a stroke, surgically clean out the blockage, and you save the patient from brain damage.
It's that simple plumbing mindset again. See a clog, scrape the pipe.
But the reality of human biology over 65 is infinitely more complicated than household plumbing. The data shows that a vast majority of adults over 65 have some degree of silent, stable narrowing in these arteries.
Yes.
It's calcified plaque that has been sitting there for a decade, it's cemented into the wall, and it is causing absolutely zero neurological issues.
But if you screen for it routinely in asymptomatic people, you will inevitably find it.
Because it's always there.
Right.
Yeah.
Let's say the ultrasound reveals a 60% or 70% blockage. The cascade triggers immediately. You are referred to a vascular surgeon. The surgeon looks at the scan and recommends a procedure called a carotid endarterectomy.
And what exactly does that involve?
This is a major surgery where they literally cut open your neck, clamp the artery, open the blood vessel, and physically scrape the plaque out of the vessel wall.
I want to make sure I understand the mechanism here. To scrape the plaque out, you have to temporarily stop or drastically reduce the blood flow to the brain, right?
Yes, you do.
And you are scraping a brittle, calcified substance right next to the bloodstream.
Yes. And what's fascinating here, in a deeply morbid clinical sense, is the cruel irony of prophylactic medicine. The surgery itself carries a 2% to 3% risk of causing a massive stroke during or immediately after the procedure.
Wait, because a piece breaks off.
Exactly. When you scrape out that plaque, you can easily dislodge a microscopic piece of debris. That debris enters the bloodstream, travels straight up into the brain, and blocks a smaller vessel.
Oh my God.
That is an ischemic event, a stroke. The intervention creates the exact neurological catastrophe the screening was designed to avoid.
There is an illustrative story in the clinical data about a patient named Robert that I honestly haven't been able to stop thinking about.
It's a tragic case.
Robert is 79 years old, living in Delaware. He walked into the hospital for this exact procedure completely independent. He was walking, he was talking, he was living a vibrant life.
Right.
He underwent the routine surgery to fix a completely silent, asymptomatic blockage. And he woke up from the anesthesia having suffered a stroke on the operating table that left him unable to speak clearly or swallow properly for the rest of his life.
And this is precisely why the clinical guidelines on this are actually incredibly clear,
Yeah.
even though they are routinely ignored in everyday practice.
Ignored.
Yes, routinely. The United States Preventive Services Task Force, the USPSTF, which is the absolute gold standard, most rigorous body for evaluating screening guidelines in the U.S., they explicitly and firmly recommend against routine carotid artery screening in adults who have no symptoms.
Wow, they just say do not do it.
Their statistical analysis is definitive. The absolute harms of the resulting surgery entirely outweigh any theoretical potential benefits of finding the blockage.
But wait, if the USPSTF, the gold standard body that literally writes the rule book, if they say do not do this, why is it still happening so frequently? How is a doctor still ordering this test?
This raises an important question about clinical momentum and behavioral economics in medicine.
Okay.
Medicine is heavily driven by habit, by institutional protocols, and by that seductive plumbing logic we mentioned.
See a blockage, fix it.
Exactly. A doctor sees a 70% blockage on a chart, and the human urge to fix a visible anomaly takes over. It requires immense clinical discipline and a deep understanding of statistical probability to look at a 70% blockage in a 75-year-old and confidently say, we are going to leave it alone because the data proves that touching it is more dangerous than ignoring it.
It takes immense courage to do nothing.
It really does.
So we've looked at the urge to fix aging blood vessels, this obsession with our biological plumbing. But this urge to intervene extends right into the very framework of our bodies. Let's move from the plumbing to the structural framing of the house itself. The third trap is the skeletal pipeline, specifically routine DEXA scans and bone health.
Right. DEXA scans are routine low-dose X-ray imaging tests used to measure bone mineral density. They're primarily checking for osteopenia or osteoporosis.
Which is a big deal, right?
Oh, definitely. Now, preventing falls and devastating hip fractures in older adults is undeniably a massive priority in geriatrics.
Sure.
The problem here is not necessarily the scan itself. The problem is the automatic pharmacological pipeline that the scan triggers.
Right, it's the reflex. The scan comes back showing lower density. And let's be clear, lower bone density is a completely natural, universal part of the aging process.
It happens to everyone.
But when that scan shows a lower T-score, it triggers an immediate, almost unthinking long-term prescription for a class of drugs called bisphosphonates. These are drugs like Fosamax, Buniva, Actonel. You see the commercials for them constantly.
All the time.
But when you look at the mechanism of how these drugs actually work and the iatrogenic harm associated with long-term use, it is genuinely horrifying.
To understand why it's harmful, you have to understand basic bone biology. Bone is not dead tissue like a piece of wood. It is constantly remodeling itself.
It's alive.
Very much alive. You have cells called osteoclasts that act like a demolition crew, clearing away old microdamaged bone, and you have cells called osteoblasts that act like the construction crew, laying down fresh new bone.
Okay, so a constant cycle of tear down and build up.
Exactly. Bisphosphonates work by effectively paralyzing the demolition crew, the osteoclasts. So you stop losing bone, and your bone density scan looks fantastic. The numbers go up.
So what's the problem? If the density goes up, the bone is stronger.
No, because density does not equal structural integrity.
Wait, it doesn't?
Not at all. Because the demolition crew is paralyzed, the body cannot clear away the microscopic cracks and damage that naturally occur from everyday walking.
Oh, so the old damaged bone just stays there.
Yes. Over years of use, the bone becomes incredibly dense, but it also becomes brittle, like chalk.
Like chalk. Wow.
And when bisphosphonates are used long-term, typically beyond 5 years, they are strongly associated with a specific severe set of complications.
Like atypical femoral fractures.
Yes. These are spontaneous, catastrophic stress fractures in the thigh bone, the femur. This is the exact, massive structural bone the medication was prescribed to protect.
That is insane. So how does it break?
A patient can literally be just standing in their kitchen putting normal weight on their leg, and the brittle femur simply snaps in half because the microcracks were never repaired.
Just from standing?
Yes. The other major complication is osteonecrosis of the jaw, which is a deeply painful, debilitating condition where the jawbone tissue literally begins to die and deteriorate.
The clinical data shares the story of Gloria, a 72-year-old former teacher from Phoenix. She had absolutely no history of falling, no previous fractures.
Totally fine baseline.
She was put on this heavy medication purely based on a routine asymptomatic scan. And 3 years later, she developed a painful, atypical stress fracture in her thigh that was structurally caused by the very preventative medication she was taking to strengthen her bones.
It's the ultimate betrayal by a medication.
It's like painting over rotten wood on the foundation of your house with a thick coat of lead paint. It looks rock solid on the inspection report, but structurally it's ready to shatter. Why aren't we just focusing on not letting things crash into the house in the first place?
That is the exact behavioral shift that geriatricians are begging for. Medicine heavily prefers a pharmacological solution, giving you a pill to theoretically fix a metric on a chart over a behavioral or environmental solution.
Because giving a pill is easy.
Exactly. But the clinical outcomes heavily favor behavior. Studies explicitly show that fall prevention programs, specifically practices like Tai Chi, improve neuromuscular mapping, balance, and proprioception.
Which is just knowing where your body is in space, right?
Yes, and it improves it so effectively that it reduces the actual risk of falling by nearly 50%.
50%. That is a massive clinical outcome.
It is better than any pill, removing trip hazards like throw rugs, installing grab bars in the shower, and simply getting your vision checked so you can accurately see the stairs.
Stuff that seems almost too simple.
But these behavioral interventions reduce your actual risk of a devastating hip fracture far more effectively than paralyzing your bone remodeling with a pill. And they come with absolutely zero physiological side effects.
Okay, so we've covered the heart, the arteries, and the bones. We've seen how fixing the plumbing and the framing can severely backfire, but what happens when the C word gets involved?
Cancer.
Because everything we've talked about so far requires a level of clinical discipline. But when cancer is brought up, the cascade effect seems to bypass all logic and go into absolute terrifying overdrive. Let's look at the fourth trap, the oncological dilemma, specifically routine PSA tests and mammograms after age 70.
This is undoubtedly the most sensitive, emotionally charged, and misunderstood area of preventive care. We're talking about routine PSA blood tests, checking for prostate cancer in men over 70, and aggressive routine mammography for breast cancer in women in their late 70s and 80s.
Right.
The core biological issue here is a well-documented phenomenon known as overdiagnosis.
And we really need to define that carefully because I completely misunderstood this at first. Overdiagnosis does not mean the test was wrong, right? Doesn't mean you don't actually have cancer.
Correct. That would be a false positive.
Yeah.
Overdiagnosis is far more insidious. Overdiagnosis means the test found a very real, actual cancer cell. But it is a cancer that is biologically indolent. As we discussed earlier, it is moving so incredibly slowly, its cellular replication is so sluggish that if you never knew it was there, it would never cause a single symptom before you passed away from natural causes, like a heart attack or simply old age a decade later.
The data on this is staggering. There is a landmark study in the New England Journal of Medicine that showed that up to 40% of breast cancers detected via routine mammogram in women over 70 are overdiagnosed.
Yes, through all day.
They are cancers that would never have caused a clinical symptom. And for men, elevated PSAs are incredibly common and mostly point to slow-growing, completely harmless cellular changes.
Yes, very common.
But the cascade triggered by finding these indolent cancers is utterly devastating.
Because the word cancer is psychological warfare. The label overrides all logical risk-benefit math. An elevated PSA immediately leads to a prostate biopsy.
And that's not a small thing.
No, let's look at the mechanism of that biopsy. A doctor uses a transrectal ultrasound probe, passing a needle through the rectal wall directly into the prostate.
Oh, wow.
You are essentially dragging gut bacteria straight into a sterile organ. That biopsy carries roughly a 5% risk of causing a severe systemic infection, often requiring immediate hospitalization and IV antibiotics.
And let's say they do the biopsy, you somehow survive the infection risk, and it confirms a slow-growing cancer. Suddenly, a perfectly healthy 75-year-old man is facing radical surgery or intense radiation.
And the side effects of those treatments are deeply life-altering.
Oh.
You are talking about severe chronic fatigue that ruins your quality of life.
Right.
You are talking about permanent urinary incontinence where you are suddenly wearing adult diapers. You're talking about permanent impotence.
The clinical data provides two heartbreaking case studies that perfectly illustrate this trauma. Consider Raymond, a 74-year-old from Tulsa.
Yeah.
Fit, active, playing golf. A routine screening found a slow-moving cancer categorized as a Gleason 6.
Now, biologically, a Gleason 6 is about as slow-moving and non-aggressive as prostate cancer gets.
Really?
Oh, yeah. The cells look almost normal under a microscope.
But he was terrified by the word cancer, so he underwent targeted radiation. The radiation caused severe pelvic fibrosis. He was left with chronic fatigue that completely wipes out his entire morning, and severe urinary urgency that dictates his ability to leave the house.
It steals his freedom.
His direct quote to his doctor afterward was, "I felt vastly better before they found it than I do now that they fixed it."
That quote just haunts me.
I felt better before they found it. That is the exact definition of physiological iatrogenesis.
And then there's Gerald, an 81-year-old from Baltimore. He was coerced into surgery for low-grade prostate cancer at 81.
81? Why are they doing surgery at 81 for a slow-growing cancer?
It defies logic. 6 months later, his surgical recovery failed, and he's permanently wearing adult diapers for a cancer he absolutely would have died with, not from.
But I have to ask, how does a patient realistically stand their ground in that moment? How do you maintain the longevity lens when a doctor wearing a white coat, sitting in a sterile room, looks you directly in the eye and says you have cancer?
It is incredibly tough.
The psychological difficulty of choosing watchful waiting over active attack must be immense.
It is arguably the most difficult psychological hurdle in all of modern medicine. The word cancer is culturally synonymous with the death sentence if it is not aggressively cut out or burned away.
We're told to fight it.
Exactly, fight the battle. It terrifies patients into accepting treatments that completely decimate their bodily autonomy and their daily dignity.
So what's the alternative?
It requires a profound, almost superhuman level of trust and clinical authority for a doctor to confidently explain that monitoring the cancer, which we call active surveillance or watchful waiting, is actually the most aggressive, scientifically sound way to protect the patient's quality of life.
Active surveillance. I like that framing. It's not doing nothing. It's watching closely.
Precisely. It's an active medical strategy.
So we've tackled the heart, the neck, the bones, and the agonizing psychology of cancer screenings. Finally, let's talk about the one test that almost everyone considers the absolute, unquestionable holy grail of responsible aging.
Oh, I know where this is going.
The test that if you tell your friends you skipped it, they look at you like you are completely reckless. But the clinical data says you should strongly reconsider it after age 75. Let's look at the fifth trap, the gastrointestinal risk. Routine colonoscopies post-75.
Right. We are specifically talking about routine screening colonoscopies in asymptomatic average-risk adults over the age of 75, particularly those who have had previous clean scopes in their 50s and 60s.
No, wait, I have to stop you. Isn't a colonoscopy the absolute gold standard of screening? I mean, it actually prevents cancer by snipping out polyps before they turn malignant. Why would we ever stop doing the quote-unquote best test available?
Because mathematically, a gold standard test is only the gold standard if the biological organism taking the test can physically withstand the systemic stress of the procedure.
Ah, okay. The tolerance issue again.
Exactly.
Yeah.
And once again, we look at the ultimate authority, the United States Preventive Services Task Force.
Mm-hmm.
They explicitly and formally recommend against routine colonoscopies after age 75.
Wow.
And their reasoning comes down to the severe exponential escalation of procedural risks.
Let's outline those risks, because when I read the mechanism of this, I was terrified. First, there is roughly a 1 in 500 chance of a bowel perforation. That means the scope literally pushes through and tears a hole in the mucosal wall of the colon, which thins out naturally as we age.
Exactly. And in a 50-year-old, a bowel perforation is a very serious but generally manageable surgical complication. They go in, they patch it, you recover.
Okay.
But in a 77-year-old, a bowel perforation is catastrophic. It means emergency open abdominal surgery.
Oh, my goodness.
It often means a temporary or permanent colostomy bag. It requires extended hospitalization, which leads to muscle wasting, and often a permanent, irreversible loss of independence.
And that's just the physical tear.
Right. Additionally, the physiological risks associated with the deep sedation required for the procedure, usually propofol or fentanyl, those climb exponentially with age, increasing the risk of aspiration or cardiac arrest.
But what absolutely blew my mind when reading through this clinical data is that the primary danger doesn't even start on the operating table. The danger starts the day before in the patient's own bathroom with the prep.
Yes. The bowel prep liquid is highly traumatic to an aging body. The mechanism is essentially an osmotic laxative.
Which means what exactly?
It pulls massive amounts of water from your bloodstream into your bowels to flush them out. This causes rapid, severe systemic dehydration. And as it flushes out the water, it also flushes out essential electrolytes, most critically potassium.
And why is a drop in potassium so dangerous for a senior?
Because the electrical conduction system of the human heart relies heavily on a precise balance of sodium and potassium to regulate its beat.
So it messes with the heartbeat.
When you cause severe hypokalemia, which is low potassium, you severely disrupt that electrical signal. This can directly trigger dangerous, chaotic arrhythmias like atrial fibrillation. You are pushing an aging renal and cardiovascular system to its absolute physiological limits just to clear the bowels for a camera.
And the case study of Margaret perfectly illustrates how devastating this PrEP alone can be. Margaret is 78 years old. She felt completely fine.
Zero symptoms.
Zero. She had a history of clean scopes in her past, but she was pressured by a new aggressive doctor into a routine scope simply because she was chronologically due. She drank the PrEP liquid at home, and it completely wrecked her electrolytes.
So common.
She became severely dehydrated, confused, and dangerously weak. Her daughter had to rush her to the emergency room. Margaret ended up hospitalized in the cardiac unit with severe heart arrhythmias for 5 full days.
And the punchline.
She never even had the colonoscopy. She endured all that biological trauma, nearly suffered a heart attack for a test she never even took.
And again, applying the longevity lens to this scenario, the colon cancer is most likely to be found in asymptomatic average-risk adults over 75 are typically so slow growing that they would not affect the patient's remaining lifespan. The immediate severe physiological risk of the PrEP and the procedure vastly outweighs the theoretical risk of finding an indolent cancer.
And the most frustrating part is that there are alternatives. It's not a choice between a dangerous scope and completely ignoring your colon.
Exactly. For those who still want monitoring or who have specific concerns, there are non-invasive, highly effective stool-based testing options available.
Like what?
Tests like Cologuard, which look for shed DNA, or annual FET tests, which look for microscopic blood. These evaluate for genuine, active warning signs without exposing the body to absolutely zero procedural or PrEP-related risks.
Okay, let's take a breath. We have just systematically dismantled 5 massive pillars of routine senior care. The treadmill stress tests, the carotid ultrasounds, the DEXA bone scans, the aggressive cancer screenings, and the post-75 colonoscopy.
It's a lot to take in.
It really is. So what does this all mean? How do you actually use this information? How do you protect yourself or protect your aging parents when you are sitting under the fluorescent lights in that 15-minute appointment, feeling the intense pressure of a doctor telling you to just run a few tests?
The clinical data provides a very specific, highly actionable empowerment toolkit to break the cascade. They call it the 4 questions protocol.
I love this part.
These are 4 specific questions you must bring to your next appointment. Asking them completely changes the power dynamic of the conversation, forcing the physician to pause their clinical momentum.
Let's walk through them because these are brilliant. Question 1. What is the false positive rate of this test for my age, and what exactly is it looking for? I love this because it stops the doctor from just ordering a test by default.
Right, breaks the habit.
It forces them to acknowledge the statistical flaws we discussed, like the 40% false positive rate in cardiac stress tests. It demands precision.
Question 2. If we find something, what are the realistic treatment options for someone my age, and what are the specific procedural risks of those treatments?
That is vital.
This is vital. Do not let the conversation stop at "we found something." You must force the timeline forward. You have to mentally evaluate the downstream cascade, the surgeries, the side effects, before you ever consent to take that first initial test.
Because once the test is taken, the cascade starts.
Exactly.
Question 3. What happens if we just monitor this instead of treating it? This is my favorite one. Because it normalizes watchful waiting or active surveillance as an active, mathematically sound, scientifically validated medical decision, rather than framing it as giving up or being a bad patient.
And question 4, what is the most effective, non-invasive behavioral alternative?
Yeah.
This brings the conversation back to the Tai Chi, instead of the crippling Dilexay pills, or the stool tests instead of the invasive bowel prep. It demands that the physician explore behavioral, environmental, and low-risk diagnostic avenues first.
But what if the doctor bristles at these questions? What if they get defensive or arrogant? Because a lot of doctors don't like being questioned.
This raises a profoundly important question about the doctor-patient relationship itself. If a doctor dismisses these questions, talks over you, checks their watch, or treats you like a difficult patient simply for seeking informed consent, that is a massive clinical red flag.
Good to know.
True clinical authority, real medical wisdom, welcomes informed consent. A good doctor wants you to deeply understand the risk-benefit math. If they don't, you need a new doctor.
I really want to emphasize this point directly to you listening, especially if you are managing the healthcare of aging parents or navigating this for yourself. Saying not right now, asking to wait 6 months, or simply saying a firm no to a routine screening is a perfectly valid, scientifically backed, incredibly responsible medical decision. Your body, your biological reserves, your choice.
The core takeaway from synthesizing all this clinical data is a profound paradigm shift. We have to change how we view healthcare in our later years. After age 65 or 70, true preventive care is no longer about aggressively finding and attacking every single hidden microscopic abnormality.
Right.
True preventive care is about fiercely protecting your quality of life, preserving your daily independence, and actively guarding your biological reserves against the severe cascading trauma of unnecessary medical interventions.
It really makes you stop and think. If our current medical system is perfectly, beautifully calibrated to aggressively search for, hunt down, and attack disease at all costs, regardless of the collateral damage, what would happen if we rebuilt it from the ground up?
That's a fascinating thought experiment.
What if we redesign the entire philosophy of medicine to strictly optimize for the preservation of daily joy, bodily autonomy, and physical independence? If the ultimate goal was simply keeping people out of the hospital and happily working in their gardens, would the waiting rooms just empty out?
They just might.
Think about that 71-year-old man from the beginning. Still happily mowing his lawn, still dealing cards at his poker game. Think about how much of his life, his precious independence, could have been completely saved if his doctor had simply possessed the clinical courage to leave him alone. Thank you for taking this deep dive with us.